So today we have the pleasure to host Professor Sharon Brownie from Australia. Sharon is a full professor in nursing. She's been working within the nursing field since many, many years. She's got a wealth of knowledge and expertise in the area of teaching and learning, curriculum development, research and innovation. She's currently a full professor at Swinburne University in Australia, Melbourne, and she's today with us, and she honors us with her presence through her appointment as visiting professor at the University of Parma. I had the pleasure to know Sharon since many years. She was my head of department when I was working at Fatima College of Health Sciences in the United Arab Emirates, and I could experience myself the abilities, the skills, and the human qualities that Sharon displays throughout her job and throughout her activities and work in the university field. So it's a pleasure to have her here, and I'm sure she's going to share with us her expertise. She developed around the world in so many countries, so in Vietnam, in Australia, in the United Arab Emirates, in Central Africa with the Aga Khan University, and many more. And we are honored to have you, and we are pleased to share this experience in this seminar with colleagues and friends. So thanks so much, Dr. Sharon, for being here, and we are all ears for you. Thank you.
Well, thank you for the very warm welcome. It's a pleasure to be here. I feel very honoured, and it's a magnificent university with big global reputation. So I'm certainly very, very pleased about that. They have asked me to provide a series of workshops that will interest you as educators. If at any time you don't understand what I say, put your hand up and Antonio will help interpret, all right? Because I speak English and I have a New Zealand, what they call a Kiwi accent. So that may be difficult for your ears. So just if you do not understand, just tell me, okay? Right, so as I say, up front and central, I come from Swinburne University of Technology in Melbourne, Australia. And I also am affiliated with the Charles Sturt University School of Medicine. And because of my interest in rural health delivery and here visiting the University of in my country, let me just see. I'm just trying to make it go to the next one. He said to press that there.
Yeah, we can just do this. Yeah, it's a bit tricky.
Just to click wherever you want. You will just to come back.
Yeah, just click anywhere. Right. In my country, and that is Australia and New Zealand, the Indigenous people, the local people, are very important. So we always start a presentation saying that I travel from Swinburne and from afar, and I acknowledge the Wurundjeri people of the Kulin Nation. They're the traditional owners of the land on which Australia's campuses and Swinburne's campuses are located. And in the fashion of where we come from, we always give acknowledgements and honour to the leaders from the past, the present, and the emerging leaders. I quite like that because it also respects what we have learned from those that went before us, but it also respects the fact that we are, as leaders, teachers of the next generation and succession planning and for the emerging leaders yet to come. And some of these sessions, this is what they're about. They are for emerging leaders, people who are either in or developing or starting leadership roles. I also like to express my thanks to the University of Parma leaders, Professor Antonio and also Alicia, Mario that came to the airport, drove me here, all the people that made that welcome for me. So thank you very much. So a bit, first of all, about introductions about who am I, right? So you'll see a little picture there of a Kiwi and an Aussie, right? So I was born in Whakatane, New Zealand, and it's a small coastal town in the central North Island on the east coast of the Bay of Plenty, right? And over the course of my life, I have 2 daughters and I have 4 grandsons. So like most people, family are very important in my life, and I'm blessed to have them. I'm in New Zealand. I did my nursing training and my midwifery training in New Zealand back in a long time ago, the 70s, right? And I've committed then to lifelong learning. So I always believe that learning never stops until, I guess, the day our breath stops, where you're still learning something. So over that time, I've done some master's qualifications, and wise or not wise, I did 2 PhDs rather than 1. And the first one is in regional economics and partnership-based work, that is working together with others, and the other one's about nursing and health service leadership. As Antonio has said, I've worked, taught and researched nationally and internationally in jobs that have been health, education, social-oriented departments like income support, social welfare departments across New Zealand, Australia, Middle East, Africa, Asia and the UK. So I've been very blessed to see many perspectives, and as the Vietnamese would say, there are many things that are the same, but different, right? So in terms of for nursing, some of the things that are the same is about the need to give quality care to your patients, look after safety, things like infection control and others. But the things that are different are the culture and the contexts. Yeah. So today, I am a professor of nursing and health workforce development, and my special interests are in health and nursing workforce, partnership-based services, interprofessional education, and today we're going to talk about interprofessional education, and regional development and capacity building. One of the reasons I like regional development is that if you think of the human body, it's no use looking after the heart if the hand or the foot's not very healthy and going gangrenous. The whole system, the whole body needs to be healthy. So all of the regions need to be able to be economically healthy and be part of the whole. Let's see if I can make it. Yeah. So today, and I've got a series of talks over the next 2 to 3 weeks. Today, we're going to talk about interprofessional education and care and the relevance of those things in addressing chronic disease, which is really increasing globally. So interprofessional education, or IPE, when you look at definitions, the most common definition is where students from 2 or more professions are learning together. So in your lecture theatre, in your practice environment, it's not just nurses, say it's nurses and occupational therapists, nurses and physios, nurses and doctors, where 2 or more are working together to improve health outcomes and preparing them for effective teamwork in healthcare. That's what interprofessional education does, is to help them to be part of a team rather than just their professional identity. Interprofessional care involves multiple health workers from different professional backgrounds collaborating with patients, families and communities to deliver the highest quality care. Now, I think that most of you in the room today are also associated with the hospital and the services. Is that right? Yeah. So I'm quite sure that in your day-to-day work, you just don't interact with nurses. There are others. There's a team that gives healthcare. And the gentleman here that's doing the PhD, you're doing that transition, you're telling me, from hospital to community, and the team that's required to be able to do that. All right. So this picture here is on my left. We have the students in their uniform there. We have a physiotherapist, we have a nurse, we have an occupational therapist, and we have a nutritionist, right? On the other side, we have a group of people from the community who have engaged in a falls preventative program. And they came at the front because they've got their certificate that they've, as community members, they've completed a program about falls prevention. Right. So if we then look at chronic disease, it's basically something that is prolonged duration, doesn't get better by itself. It's really cured completely. You can manage it, but you often can't cure it. So you're getting people to live with and accept diabetes, schizophrenia, chronic nephritis, bad osteoarthritis. So you can't necessarily cure them, but basically you are looking after them to provide the best care so that their life is the best possible with the chronic disease. Sometimes they can go into remission with good care, sometimes not. And there's usually a whole range of complex factors leading to the onset. So for example, diabetes, it's usually after 30 years of eating the wrong food, not exercise, having the thing we can't control is who our parents and our grandparents are, the wrong genes, you know, the ancestry. So there's multiple factors that have caused it. It's a long development period. A lot of these things, when people are 20, 30, 40, they think it doesn't matter, but it's quietly hatching in the background. And prolonged courses of illness, and perhaps those lead to other complications. Again, if you look at diabetes, it leads to glaucoma, foot ulcers, amputations, chronic kidney disease. So usually one is like a slippery slope leading to the others, and often ending up with functional impairment or disability. So what I've put on there too is that if you want to have a look at some of the source of those definitions, etc., those things are there. Right. Why is it even important for us to talk about this? When you look at the world population, in most countries of the world, and certainly what's called the G8 nations, often the nations that have been originally more white, in terms of Germany, Sweden, Italy, some of Australia's in the G8, etc. And those countries have gone into negative birth, right? Not enough babies, right? Lots and lots and lots of people my age group, the baby boomers, that are starting to retire. And people are living longer, but not necessarily better, right? So non-communicable disease last year killed 43 million people worldwide. So those were things that are chronic and not. And the highest cause is cardiovascular disease, killed 19 million, cancers 10 million, chronic respiratory disease 4 million, diabetes another 2 million, and diabetes is really on the increase. So like when we think about the health system and how it used to be, and in so many places how it still is, you have a single visit to the doctor. You've got one of those things, you go to the doctor in a linear thing with one professional, mostly going to the doctor, right? But now the new models of care require a whole program of care rather than just single doctor's visits, because you need teams of health professionals working together, and And the solution to these things actually can't be fixed on one visit in a doctor's office, right? It has to have social and behavioural change, right? So when you get to think of the diabetes, which is a big problem where I come from, the social and behavioural change, you've got to get people to eat different. What we eat, when we eat, how much we eat, is really socially and culturally defined, right? And also they become habits from early childhood. So to address chronic disease, you have to have new ways and new models of care. And at the heart of that is social and behavioural change. So you have to have, you may still go to the doctor, that is important, who oversees the care, and then basically you have to have the physiotherapist, the nutritionist, over many weeks, the things that you need to do, sports and exercise science, etc. But we don't necessarily teach students like that. We usually teach students just in their profession. Right? So if I have a look at Italy, I had a little look at that, right? So you've got a total population of about nearly 60 million. 24 million, that's 40%, have already got at least one chronic disease. That's nearly 1 in 2, not, okay? 11 million of Italians have hypertension. Cardiovascular disease is the leading cause of death. 4 million people fell down, they had falls and injured themselves. And 3.7 million people here in this country have diabetes already, right? So the government, they know about that. They know it's there. So they've developed a national chronicity plan, right? And I've put that there, and I put a little quote from it. The plan recognises the need for better management of chronic disease. And the Italian government launched the National Chronicity Plan in 2016 to improve coordination of chronic care and implement regional policies and programs. And I have put some of the reference there if you want to follow that up about the chronicity plan. And also I put a reference in there that I thought about monitoring and patient falls. Now in Australia, in Melbourne, which is a city of say 8-9 million people in the city, right? And the Alfred, the hospital called the Alfred, is the largest ED place, right? When you look at their statistics over the last year of people that came in and had to be attended in the ED, couldn't be sent away to a GP. The single biggest cause of an ED admission and then later mortality or morbidity was falls and people over 60 from falling from under 1 metre, right? That's the single biggest thing that comes through the ED. People fall on stairs, they trip over ironing courses, they trip over little steps, and because they're older, they break hips, they break ribs, and a lot of this, so this is not about, yes, some construction workers may fall off the roof, but most of the falls are in older people over 60 and falling from something that's no higher than 1 metre. So a lot of it's trip, etc. So big problem. So I guess now we've set the context of the world and in Italy. And so I thought that I would spend some time telling you about me and some of the things that we've done in interprofessional education. So back in 2020, 5 years ago, or it was late 2019, before the pandemic, I secured a $1.5 million grant to establish a student-led interprofessional clinic. So the purpose of the clinic was to allow some experiments and innovation in student education while they were still learning to be nurses and OTs and physios and nutritionists, while they were still learning to actually, during the course of their studies, have some interprofessional education, both in theory and in practice. And the practice occurred during the programs. And we went out and we talked to all our community partners and said, what is the biggest problem that you're seeing every day? What do you need us to deliver programs, rather than us sitting at the university and deciding what the community wanted? So it was about falls assessment and prevention. That was number one thing they came up with. Pre-diabetes care. A lot of them said, yeah, we've got diabetes clinic, but we want you to focus on the pre-diabetic before they become diabetic. Free community health screening, because we want you to help us pick up these things early, and health education promotion. And so that's what we built our programs around. And we started first with nursing, occupational therapy, physiotherapy, dietetics, and nutrition. At the end of last year, we were also starting to add counselling and psychology, because it's also that social and behavioural change is also about headspace. If you're going to get people to, like my mother fell many times and had fractures, right? She kept saying, when we said to her, have a walking stick when you go out, she kept saying, I'm not old. She would not change her mind. She kept falling down and breaking things. So some of it is about that behavioural change. And so that's why counselling and psychology students are also good to have in the mix. So we delivered this with a lot of our community partners, and those are just some of the community partners. So we listened first up to the community to ask them what they wanted and what they needed and what programs they thought would make the most difference. Now, the thing that we did then was that as a bunch of tutors and researchers, it wasn't us that designed the programs, because this was going to be a student-led clinic, right? So we got the students as part of their coursework and started assignments. The students designed the programs, and then we got the community to come in and critique and assess the programs and say, yes, we think that's a good way of going about it. We then got ethics approval alongside every single program so that we could talk to the patients and talk to the students and evaluate it from a student point of view and from a patient point of view, and that we could publish it, right? So the falls prevention program, it included, first of all, we would get the referral from the GP and the hospital. So one place we were getting the referral was from the hospital rehab wards that were sending people home. They said, we want them to go out there, but we don't want them to fall down again, all right? So we would get the referrals. So the first thing that we would do is we would go out with our nursing student and an occupational therapist. Now, in New Zealand and Australia, occupational therapists are licensed to do home safety risk assessment. So you go there, the front step's too high. Inside, the carpet on the steps are loose. There's too many mats. The shower or bath hasn't got a handrail. So the first thing we would do is do a complete assessment of the home, and then we can get funding from an organisation called ACC, Accident Compensation Commission, to help reduce the risks at home. So first up, you take out all the things that are obvious things that they're going to cause them to trip up. Like things like the TV's there, the plug is there, and to go to their armchair every day and sit down, they have to step over the cord, which is that far off the ground. So it needs a new plug so that that hazard is removed. So first of all, home visits with assessment of the falls hazards. Then we did an individual training session. So each person would come in and they would have an individual consult with physio students and exercise sports science students around what a good program of activity was for their age and stage, physical capacity, etc. Right? And then we basically had group sessions, and you'll see some there, the one that's like this at the back. We have some migrants within the Asian network So those was a group in the Asian network. And you'll see on the bottom there, the gentleman that's, and the chair and the nurse kneeling down with the physiotherapist actually, and that actually doing some individual discussions around what that person's need. And this particular gentleman had an accident and was being discharged from hospital. Right? And then we did the monitoring of the falls. And on every situation, because we were a university student-led service, we developed forms and we would send them back to the GP so that the GPs loved it. GP said, we don't have time for this. This is very good, right? Yeah. So the falls program, whoops, I've got an E missing off there. The program runs for 8 to 9 weeks. And we also included collaboration with exercise physiology students from our biokinetic clinic. So we have a qualification in New Zealand, which is called a licensed exercise physiologist. It's similar to physiotherapy, but physiotherapy has a greater focus on people who are really unwell and also sports components. So we got those clinics to collaborate, and each person received an hour of individualized exercises. So when they went home, there was an hour of things that they could do over the course of the day in short little periods, etc., and a 30-minute slide presentation on different topics and questions and answers. And there were so many things that the people from the community asked about that no one had ever told them about, like how to not trip up at home, that, you know, like if you've got a bicycle that's got 2 wheels and you have a tricycle with 3 wheels, it's a lot harder to fall off a tricycle, right? So therefore, if someone has a walking stick, suddenly they've got 2 legs and a stick. It's harder to fall over. Some basic things like that we were teaching people. Every now and then it doesn't want to go to the next slide. Yeah. So then we also did free community health screening, and we would involve a lot of nursing students in this, plus also students from dietetics and things like that. So the program included blood pressure monitoring, lipid testing. So we were teaching students to be phlebotomists and draw blood, right? And we got a grant so that we had our own HB1AC machine that we could do on the spot just about and tell them what their glucose levels was looking like. And we ran this health screening at the clinic. So people could come into the clinic on the campus, on the university campus, on community events. So if there was a flower show or an embroidery show, or we would take our students and set up a stall, and everybody that came through the show could have the screening. And inside shopping malls, right? We would get the permissions to go there. And then we would send the results. We would give a copy to the patient, the person, and we send the results back to the GP. And also then people from that could come to the pre-diabetes program, or the people from that could come to either the falls prevention, depending on where they were. And the community loved it, the students loved it. And remember all along the way that students did this under the supervision of a student tutor. Students were at the front running the falls programs. Students taught the classes, and it was student-led. Yeah. So basically, we had a program running alongside of that, of continuous research and evaluation. And we were able to produce over a 2.5-year period, 12 peer-reviewed publications, right? And an ISBN badged book. And the publications, I think 90% of them are Q1 and Q2 publications. We had Prof. Victoria Anderson, we had the gentleman going on the top right, we had Patrick, who's a specialist quantitative researcher in the demographics of inequality, Jay Rong, who was a lot of our interpreter with Asian communities, Marin, who has a background in terms of what we call it, his lineage, his whakapapa is Māori. We had Kesava, who's from Central Asia, Isaac from Ghana, etc. And so we had a broad range of people with different perspectives helping us with these research papers. So those are the lists of the publications that we have achieved in the 2.5-year period. I think they start at the bottom from, let me have a look there.
21.
Yeah, 21 through 24, right? So what we felt was that because it's an innovation of changing education, you should kind of always evaluate alongside of it. We're going to put all of these publications together in a book with different chapters. So the first thing we did was we looked at, are student clinics any good? What are the health outcomes that you get? Do you get improved health outcomes if you involve people in clinics, student-led clinics? Do you get better access? Then what are the educational outcomes like? What do students learn, right? Because this is a university and education as well. Then we looked at, so how many of these things exist in New Zealand and how are they structured and what do you learn from it, right? So we started off our research doing that, right? So the next lot of research we started with was, okay, we're going to teach students in the student-led clinic. A side benefit is that patients are getting treatments and preventions that they may not have access to before, but the primary cause is that we are teaching students the experience of interprofessional practice, right? So what competencies are needed for interventional practice? So we did a nationwide, it's a bit small there, but we did a nationwide study with a Delphi thing across 13 professions to get consensus on interprofessional practice competencies. So on the basis of that Delphi studies and the competencies, that's what we expected the students. So we didn't want, when we try and get students on placement and I go and talk to the physio program and say, this is good for your students, they'll say, no, we have these are particular competencies. Or then you go and talk to a, no, our competencies are this, right? So we ran the Delphi study with all of the professions to get them all to agree, right? And then basically we also then went, because then they'd say, oh, well, but our accrediting body, the physiotherapy board or the nursing board or the midwifery board, they require this or this. So we also went to each of those boards and we looked at what the regulations said, what the accreditation standards were, and then we put those all together in a publication. And we looked at all the common threads from our competency work and for what the regulators said had to be in a program. And all of them, guess what? All of them said you had to be doing interprofessional education, and then we put that together. Then we started running the programs, right? And there was 2 lots of research that we did, right? One research was about the actual teaching of interprofessional education, right? So in those papers there is an article, an extensive article where we did a big literature review about what were the tools, the assessment tools and the assessment surveys and the assessment aspects and ways of doing things that tutors could use to assess interprofessional outcomes. So if you're going to assess your students, how would you assess them? So we did a literature search about that and we published that. So there's one there about faculty tools for interprofessional education. Then we said, hang on, we also want this to be student directed and we want some student learning, right? So if we're going to say to the student, you assess your own interprofessional competencies, or you get your class rate and mate in peer assessment, how would you go about that? So all along the way, we never said we're just going to make this up by ourselves, we always went to the literature to find best practice. So another paper that went out either early 24 or late 23, there's a paper in there that's about tools for student and peer assessment of interprofessional practice, right? So after that, we decided, so that was one thing, we looked at what was important for the teaching, right? And the practice and the assessment of interprofessional practice in the context of student-led services, right? And then the next thing we looked at was basically, so how ready are students, all right? And there's a thing called readiness for interprofessional practice, because you'll get some students saying, I'm here to be a nurse, or I'm here to be a doctor. What is all this about, right? So we put those through the program, and that we measured what their attitude and what their readiness for practice was at the beginning. And then at the end, after they had the placement, we measured it to see if their attitudes and their readiness had shifted. Now that paper, we've still got that one in draft form, and we'll submit it in about 6 or 8 weeks' time. So then we started to think, well, what should we research next? And it was, well, we should research what students actually thought about this placement. So there's a wee paper in there about students' perception of the placement. Then we started to think about, well, we better think about what about the people that attend? What do they think of it all, right? And so basically we then went through that, and we've got papers there about student-run falls programs for older adults, a pilot study, we published that. Then packaged student-led on health screenings, we published that. So we've done publications related to all the programs. And I realised I went through the slides that somehow 2 or 3 slides have fallen out of here, and I will put them back in and give that to you as the final version, Antonio. And the pre-diabetes thing, we also spent time with them, and because our university in Australia and the ones in New Zealand, they train dietitians, nutritionists, and chefs, you know, and cooks. All right. So there's big training kitchens. Yeah. Yes. Training kitchen. He wants to know, Antonio, can you explain that? So we have chefs, nutritionists, dietitians, and we have training kitchens on site.
Okay, so training kitchens. Yeah. So
Okay.
this is when they can go and practice. Yeah.
Yes, yeah. So the diabetes program, and as I say, the slides with the photos, I had some photos, I don't know where it's fallen out. Part of the program is that we blended with the chefs and the cook students, and we got them to actually prepare meals, and then they sat down, the people sat down and ate the meals with our students, right? So they, rather than just giving them a presentation about you've got to cook healthy, we actually got healthy recipes. We then took them to the kitchen, we helped them prepare those, and then we sat down with them and we ate them. And then we asked them next week, how did it go with your cooking, right? So it had a real practical component about it. It had the theoretical component, and then it also had the component about an individualized exercise programs for them as well, which were really important. So those are the main programs: falls preventions, pre-diabetes, health screening, and some community education. The students afterwards, most of them said it gave them, and there's a paper there all about a telehealth thing that we did during the epidemic. It increased our confidence. Often we go on practice and we are still the student, and we're observing, and we may have some autonomy, we may not, right? Here, the students were able to help design the programs, help evaluate the programs. The students were able to lead and teach the programs. And when we did the Falls program with our Asian network, most of them were recent migrants and they couldn't speak English, right? So the Asian network provided an interpreter, and the student taught. And the students were so happy afterwards. They said, we've never thought that we could teach something, but we know how to work with an interpreter now, right? So we actually taught students how to work together as a team. One of the things they said, they understood better the roles of other people in the team, how to work together, and the confidence for them under supervision to be leading in program design and delivery from quite an early age and quite an early stage in their program. So I had there some discussion about all of this because I thought you don't want to listen to me for 2 hours. About on your day-to-day work as you go around, what are you finding is the most pressing chronic disease issues that you encounter in the populations that you serve? What do you see every day, you know, in your practice? Like even as a midwife in New Zealand, right? I would say, they would say, depending on where it is, 40 to 60% of pregnancies are now in the high-risk area, right? Many of the mothers are older mothers, like what we used to call a grand primip, laid down the back that does midwifery, all right? So you used to be an elderly primip if you were 25, right? Most people are now 35. So many people are coming in quite a lot older, right? Having had trouble conceiving, the babies, the pregnancies are very precious. A lot of them, there's a lot of obesity of the mums in pregnancy. There's pre-diabetes in pregnancy. So even in every area of practice, chronic disease is now pervading what we see and do every day, right? So the thing that I'm interested in, the question for yourselves, is that what's the most pressing chronic disease that you encounter in your day-to-day work? And the next question was, have you included any interprofessional developments for your students in your nursing program? And if so, yes, yeah. And if not, what ideas do you have to implement them? Because the curricula for each of the programs that I've taught today, I have them, and you can have them. I can share them. Like, yes,
May I ask you
yes,
something?
yes,
So you are asking my students about the chronic disease.
yes.
Yes. I ask you about the disability of the big persons. Okay. Even this disability can be a chronic disease, but we can heal this disability.
Yeah.
And also is present.
Yes,
How many important can be in an educational program to allow the student and bring them or understand that inside this all those chronic disease, that can be some disease that we can see and heal. And I think that this is a great sensibility
yeah,
we can make with the students.
yes.
Don't you think that?
I do. So really what our community was saying to us, by doing community health screening, we were picking up quite a lot of things that were not seen, that people did not know, right? And there was never a clinic that we would go out to a shopping mall for a couple of hours or to the Asian Network meeting or to, we would always pick up 2 to 5 people who had pre-diabetes or full-blown blood sugars, high levels of diabetes, or would talk to us about chronic issues that, like sleep apnea, etc., that they had, that they didn't know, that was otherwise invisible in which they had not necessarily been to a doctor. They kind of thought, I'm 45, I'm 50, I'm healthy, why don't I go? I don't need to go there, right? One that was frequently picked up that people had no idea they had was high blood pressure, right? So if the high blood pressure is picked up, and one of the good things of going to a shopping mall is that you've got people from young to old, right? So if you pick up a 28, a 35, a 42-year-old that's running a high blood pressure, right? So they can sail along till their mid-50s, late 50s, and all of a sudden they have early heart failure because their heart's been pumping so long for so many years, right? Or they have a stroke because they didn't know. So you're absolutely correct. So we found that the mixture over the course of the week of health screening, plus then those two programs were really important because it was detecting stuff that is hidden that people didn't know about. And then you could meld it with the, so if you detected high blood pressure, if the patient would tell you who their GP was, we would send those findings to the GP, and then we would invite them to some health education sessions around what high blood pressure is and why it's important that they look after it and attend to it. So the kind of the package fitted together like that. The issue is for yourselves, if you wanted to do some of this like this, is how much flexibility do you have in your program that you can build in, like the health, just the health screening one, is you don't need to have a formal kind of clinic established, you don't have to have a formal whole placement, but you know, in some of your courses on an afternoon, you can, out the front by the bus stop, set up a stall for free health screening and take your students out there. There are many things that you can do to simply start slowly with some of this work. Anyway, we have found it a lot of fun, a lot of hard work, because we, as I say, publishing 12 papers is a lot of work. We're going to put them together in a book of readings now. And we'll go from there. But one of the things we found is that people have been talking about interprofessional education and team-based care for 20, 30 years. And in most places, it's still not happening. And the reason it's not happening is that it can be hard. It can be hard enough just to run your nursing program with trying to kind of put this stuff in it. And if you're going to put something like this in here, what do you take out? And if your accrediting authorities don't require it, why would anybody do it? But suddenly we put a nurse into the hospital or into the community and we say, hey, work with all other members of the healthcare team. But maybe we didn't teach them how to do that in practice or during training. So that was my bit about, interprofessional advocate, which is team-based care and practice, and that's what we've done, and that's what we've, and any ideas, and as I say, if you wanted a copy of the Falls program or a copy of, happy to share that with Antonio. I really believe knowledge should be shared and disseminated, and that people shouldn't have to start from scratch with a blank piece of paper. But it was fun getting the students. The other thing is that we started to get a better understanding of who the clients were. So with the Falls program, we found that there was two distinct groups, right? There was people who were 55 plus, and they usually had quite a lot of chronic disease, from pre-diabetes, foot neuropathy, so they didn't feel their feet too good, overweight. They were younger, but they weren't particularly well. They weren't well. They had issues, all right? So that was one group in the Falls program. And then the other group were late 80s to mid 90s, right? And they were healthier, right? Because they looked after themselves, and they're 20, 30 years older, but they were frail. They were getting frail, so they wanted to know about, how do I not fall down when I'm 85? Because if I do and I fracture my hip, it might be the end of me. Yeah. So we had two distinct groups, because first of all, it was just anyone from the rehab or for the thing, and it was overrunning it over a 6-month period that we started to notice, and we started to look at the profiles of the people that came and found that there were those two distinct groups. One was the frail elderly, and one was a bit younger, sometimes 2-decade younger, but with multiple chronic diseases and they weren't well, and so they were at risk. So, there's, my daughter's recently done graduate entry nursing. She is a planner and has worked as a planner for 15, 20 years, and she's got a master's degree in planning. She suddenly decided she wanted to be a nurse. So she's come and done graduate entry nursing. And I watched one of her assignments, and she was looking at a scale for, a risk of falls assessment scale, a falls assessment risk scale. And what she found is that there's lots of falls risk assessment risk scales, but there wasn't one specific to diabetics. And yet diabetics are even at greater risk of fall for two or three reasons. One is foot neuropathy, so if they've got loss of feeling in their feet. And then the other thing is eyesight problems. Yeah, if you don't see so well, and if you don't fit, and if you don't feel your feet too well, you're going to bumble along and trip up on things. So, there was a piece of work, for somebody to go and prepare a specific diabetic focused falls assessment scale and validate that. And I guess that's the other thing along the way, is that if you are looking to build your research profiles, that doing something like this, we evaluated it and published it at every conceivable opportunity. If we could write about it and publish it, we did. And we got, right from the outset, we got an ethics clearance to collect data from students, tutors, and the community. And we put that through as one ethics clearance. And that was we almost got expedited review of a lower risk ethics. And then we had ethics clearance to collect data from patients. And that was complicated, because as soon as you start to get into that, it's your database, your security of health information, your, lot trigger. So we separated those two ethics out, and we got both of those clearances. So then we could write and publish and share what we were doing. Okay. Any other questions?
Really remarkable, but the curiosity, when do the students do these activities with patients? Doing the nursing group is a sort of, subject, it's a sort of internship. What is this?
Yeah, okay, yeah. So how we ran it was that we had these programs running, right? So when the students, say for nursing students, most students have acute care placements and primary care or community care placements. Yeah. Do you have primary and community care placements for students? Yeah.
I think during the third year of the course.
Yeah. So when the nursing school or the physio school, they said we've got 100 nursing students and 100, we need to find 100 primary care placements. This was a primary care placement, so they could come for a placement, right? While they were training, right? The trick is, the challenge is that you want them coming from a nursing program, the physio program, and the IT program. It requires the program heads to talk together and collaborate and cooperate, which is why this is about, collaborative practice. and why 30 years after talking about it, people will say, I've got my program set there, and I always send them on practice here, and I send them on a 4-week block, but we only do 3-week blocks. You've got to sort some of that stuff. So yes, these were all students in training, yeah, undergraduate students, and they loved it.
So
Yeah. So it's basically, for a primary care placement for a nurse, they're traditionally sent to the GP's clinic, GP's office, out with a community health nurse, something that's specifically nursing. But they still delivered their competencies as a nurse for the placement, or their competencies as a physio, but they also had the universal interprofessional competencies, and everything about, like, all of the stuff about what those competencies were. Some of it's in the published papers, but the competencies, the scales that we use, the assessments that we use, the pre and post, I have all of that, and I'd share any of it. You just can give it to Antonio, any of it that we did. So yeah, we did it during training. So it wasn't of a scale that, so if there's 100 in the course, right? Maybe over the course of that final year, 20 to 30 of the nurses might have been able to come through. We didn't have a big enough clinic for all of them. So the next big step, to embed it for every student into a program, that's a bigger ask. And it really requires you to sit down when your curriculum review is due to actually talk with your colleagues from other professions of how can we align a module that is common to all our degrees and a placement that is common to all our degrees. And the other thing is that we were very careful not to do things that competed with other providers and upset them. So we, I will bring the pictures to my next session. I don't know how those slides fell out, but like when we talk to the communities, they say, we are funded and we get money to develop diabetes care. We do not want you to do diabetes care, right? But you can do, nobody's doing pre-diabetes, please do the pre-diabetes, right? So when you think about the legal scope of practice for a student, pre-diabetes is fine, because you're teaching them about exercise and you're teaching them about how to eat right, you're teaching them about, you're not getting students in a clinic to manage their diabetes. So you don't have that big medical legal risk. The same as a falls prevention program. You're not competing with poor health services because they often don't do them. The community screening program. So we needed to think about what was safely within scope of practice. That's right. Safely within scope of practice, and was not competing with mainstream providers, or was not delivering medical interventions that were problematic. Sort of what was that glass of water? I hope that makes sense. Yeah, hang on. Yes. Go ahead with the question. Yeah, good.
How can we preserve the nursing identity when university students and the access to the program, interprofessional program? I read 2 years ago that I led in this program in Switzerland. They try to teach to nursing students concept of other type of professions like and students say that then we really worry about them and their identity as a person. So they said, okay, but this is our technologies, this is the policy, so how can the concept I can preserve the identity as my identity?
I would have liked it to distinguish I would have liked to do the same question. In fact, today I receive also as an preparation to cooperate with other students, with other, I don't know.
Yes, we had an orientation program, all right? And we also, at the outset, we ran the scale called Readiness for Practice. And then we did an orientation program of what the program was going to be, what they were going to learn. And to teach them that you were still a nurse, you were still a physio, you were still an OT. This is your profession-specific things, but these are the team behaviours like conflict resolution, right? Communication, interprofessional writing and documentation, right? So yes, you do need to prepare them, and you will find that most of them like it, and most of them we got amazing feedback afterwards about where they felt it took them on their journey, also how much confidence it had given them is that they could help lead, that they understood what their role was and specific to other professions. Because yeah, when you go in blind, it even still, but you don't win them all. You'll still get one or two, I don't think of the right word, stroppy. What's your Italian word for stroppy? You're kind of like opinionated.
Yeah, so let's say misperception.
Yeah, you'll get some like that still kind of think, well, I'm here to be a nurse. What's this about? Give them a little bit of time and practice, and they'll know how important it is to interact with other professions. But yeah, a lot of this is around breaking down barriers that have existed in the past in terms of, the professional tribalism. Yeah.
I think, Sharon, one of the reasons why they asked this question is that here, especially in Parma, in this area, there are still so many misunderstandings and misperception about the scope of practice of nurses.
Yes.
Especially when this is seen from the perspective of medical doctors.
Yes.
So they tend to see things that are not quite there, and they tend to be quite sometimes defensive on the scope of practice, and they say, no, this area is our area, you shouldn't overstep in something that is not your area of practice. And I think, and students, first year students, they asked me exactly the same questions when I was delivering some classes on thermodynamics.
Yeah. So it's actually a worldwide problem. It's a lot worse in some places. Like if you go to Pakistan, it's quite extraordinary. Pakistan's the only country, and I've worked in and out of there, the only country I know of that graduate more doctors and nurses. And they see nurses still as the old-fashioned view of handmaiden and a bit of a threat. And I worked for 7 years as the Chief Executive Officer for the Royal Australian and New Zealand College of Psychiatrists. So postgraduate medical specialists, doctors who became special medical psychiatrists. So you have psychiatrists, you have psychologists, and you have counsellors. And you have a whole lot of people trying to protect the boundaries, right? I worked with a president, a psychiatrist, who's always said, your response to any of this threat and misconception about this is your job, this is my job, your response is always, there is always more than enough work for everybody. When you see that waiting list queue with nobody in the line, then you need to worry about this. And in the meantime, there is more than, so doctors are very special, they have a high level of training, they're really needed. And specialist doctors are even more important. If I have a berry aneurysm in my brain, I want a highly trained specialist to look after that. I don't need a highly trained specialist to do community health screening on BPs, right? And so I always counter those arguments with common sense response and the constant reply, there is always enough work for everybody. What is the wait list time for an appointment in your surgery? What is the wait list time for, how many people wait for a year to go and see a specialist, and when they get there, the solution was something else, and it was something else that could have been done and resolved. I flew over here with Emirates flight, right? And they have this chat show, talk show running all the time. Put your headphones on and you can watch a movie or you can listen to this. And there was a gentleman there in the UAE that said by 2040, the single biggest profession doing leading primary health care on the globe will be nurse practitioners, right? That doesn't diminish the role of a general practice, or doesn't diminish the role of a medical specialist, but their scope of practice, they need to focus on what it is that they are really important in doing and allow nurses to work to their full scope of practice. You're never going to get universal health care. You're never going to get everybody being seen and having access unless you actually release nursing capacity and right through to nurse practitioner level. And our country's nurse practitioners also, they have pretty comprehensive prescribing rights. Where even pharmacists down when like before I came up, I was very good. I went and I got a booster update for COVID, for influenza, and I had a booster for whooping cough because there's global outbreaks of whooping cough at the moment, right? I don't want whooping cough, right? So I didn't need to go to my GP for that because I can go to the pharmacist, just walk in. I've got my international passport of vaccinations. They can give it. Like, why do you have to go to the doctor and spend a doctor's valuable time to say, yes, you need your annual flu shot, and here it is, and I've just taken an appointment with a highly qualified health professional to do something as simple as getting an annual flu vaccine. So in the countries I come from, Australia and New Zealand, you don't even need an appointment. There's a sign on the footpath, walk in, vaccinations available. You can just go do it. So I think the world is shifting, but there's areas now where there's a lot of boundaries, professional tribalism, etc. You just keep working at it and just keep answering that question. More than enough work for everybody. Look at all these wait lists. What's going on? Oh, we need more doctors. No, the solution is let's just put the work where the work needs to be.
Also allow to collaborate and understand each other with what you are doing. If I understand what really physicians is doing, because we had these programs together, or he was my teacher, maybe in the future is the collaborative and group.
I worked in Africa for nearly 5 years, and I had a base in Kenya, and I had campuses in Tanzania and Uganda, and projects in South Sudan, Upper Egypt, and Mozambique. And nurse training there is a 4-year degree. It's really, really rigorous in terms of the science expectations. But they are nurses, they're mini lab assistants, they can suture, they're out in clinics all by themselves. They have to be able to take blood, be their own lab, look down the microscope, decide whether someone's got malaria, decide whether somebody's anemic, whether that mum who's going to deliver a baby next week has only got an HB of 9. The nurse does all of that stuff across Africa. Without that extra year in the degree and without that level of qualification, many more people would die.
Thank you so much. I
Okay.
think your talk and the presentation was full of insights and so valuable contribution to so many reflections. And I was wondering about the many challenges that you encountered when you came up with this idea of getting more students in a student-led clinic. And it seems to me that there was a massive change in terms of behaviors and attitudes, both from students and from the community members. So it was very, very effective in changing the way they perceive their role and the ability of community members of our community benefiting out of this initiative. Do you think that those initiatives, including the therapy study, may improve the way professionals talk to each other, and they can definitely maybe improve the way they interact and perceive their respective roles?
Absolutely. And yes, while we faced a lot of barriers and we overcame a lot of the barriers, this was very much to a pilot that is not embedded across all programs in New Zealand and Australia. Our countries and all programs have got a lot to keep learning, which is one of the reasons we found it so important to actually publish it, so it's more visible. Yeah, but yes, no, much greater respect in terms of, you know, physiotherapists saying, oh, you know, oh, now I know what, an exercise physiologist saying, or a nurse saying, oh, now we know what so-and-so does and why their role is important to us. Or, Okay, so I think I'll talk to you again on Monday or something or other like that. Can I talk to you about OSCEs and all kinds of other things we've done?
Yeah.
Good to see you.
Thank you so much. Thank you.